So let's kind of going to overview and look at low-grade upper tract, urothelial carcinoma. We're talking about urothelial upper tract disease, and it's already, such a small portion of patients, and then low-grade on top of that, right? We know that. So to the urologists here, right, we know that diagnosis and, staging and grading can be very complex. Anybody have any tricks that they use in their practice when they do, you see a tumor and you're going to take a person for a ureteroscopy to ensure that you get a confident diagnosis of low-grade versus high-grade disease?
Tissue.
There you go.
Take plenty of biopsies. I think I use the Piranha biopsy forceps. I think that I don't use the big opsy, but and you can use a basket. I know we've talked about that, but I think as much tissue as you can get and proper handling of the tissue, I think that's really important.
Sure.
I've used some of the smaller graspers before, and I've routinely at the early career and at the beginning and noticed that I wasn't getting enough tissue for diagnosis, and it can be quite frustrating. I do send a lot of cytology from up there. I think that can be helpful as well. But I have recently transitioned more to some of the bigger graspers, and it's a little bit more cumbersome. Sometimes I do have to put an access sheath up, but I think getting that diagnosis is so critical in terms of management afterwards. So.
Yeah. So when you see a patient like that, and it looks like they have disease, and you're taking them in for a ureteroscopy and a biopsy, do you try to do an endoscopic ablation to completeness at that time? And what's the discussion you have with the patient pre-op, setting yourself up for that? Anybody?
Yeah, so I tell patients with any tumor in the upper tract on CT urogram that we need to evaluate. Number one, we have to do cystoscopy to make sure that there's no bladder tumor, and we will take care of the bladder tumor at the time of ureteroscopy. Secondly, I talk with them about getting urine sample for cytology. So when we talk about risk stratification, it's the cytology and the pathology that play into the risk stratification, right? Not infrequently, you see some discordance between cytology and pathology. And so in my mind, if a patient have high-grade cytology and a low-grade pathology, that to me means tumor heterogeneity. That patient probably have high-grade tumor somewhere, but we just have not biopsied it yet. And then to your question about ureteroscopic ablation, I try to get good tissue specimen for pathology first before it gets bloody, and sometimes it's difficult to see. And then if the tumor look amenable to complete endoscopic ablation, I will try to do that without risking, perforating the ureter or putting them at that additional risk of upgrading.
Sure.
Yeah, I'll just comment. I mean, your operative plan, like anything, begins in the office, right? So patients referred in, you're looking at their imaging. I mean, I have had a patient referred to me with, low-grade upper tract, and you look at the images and they've got what looks like an infiltrative mass, and that's not right. So that's clearly someone who's been undergraded. But, evaluate the imaging. The radiologist don't comment on those nuances that are important to us. Is there any, what's the size of the mass? Is it really truly visible on the imaging, on the CT urogram? Is there any sort of stranding in the fat around the renal pelvis or ureter where it is? Is there any non-clinically enlarged adenopathy? I mean, all of those subtle things. And then the other thing about the patient is, what's their renal function? Where will they be in terms of risk of dialysis if you do a nephroureterectomy? Is this someone you're really going to try to manage endoscopically because to keep their renal reserve? So all of these nuances I think are really important when you're addressing them. And then, yes, you have the discussion of, we're going to, depending, we may try to laser ablate everything, or may, laser ablate as much as we can and then go on to further, UGN-101, Jelmyto therapy. So, yep.
Yeah. I think upper tract endoscopy is probably one of the hardest cases to plan for. And I think, like Adam said, you do a lot of counseling in the office, and then you end up writing out this consent form of your procedure, which is like this long: possible ablation, possible stent, possible this, possible that. And I think, definitely imaging is so critical, but sometimes you really don't know what you're going to get until you get up there. So for me, it's really just tumor size and whether or not I can safely ablate it. If it's a small tumor, less than 1 centimeter, you're there already. I probably would take care of it. But if it's something that's, more greater than 2 centimeters, not even going to try,
Sure.
My favorite
Unless
question from the team in the OR, which cases are going to need laser for? We'll see.
Yeah.
Yeah.
All of the above.
Yeah.